Meeting, you're consenting to be recorded. Okay, I'll just click that. All right. I'm very excited and happy to be invited, and it's a pleasure to be reunited again. Also, to be talking in front of TACAM, by which I used to be a member of when I completed my studies in Michigan, and I'm very happy that we also got connected. I think that was through one of the webinars that I gave, and then Dr. Mehmet was also watching that webinar, and then through that we kind of like got connected. And so tonight I have the pleasure to talk about neurodevelopmental disorders, which is an expertise and an area of interest, clinical interest of mine, that I got kind of interested back in Turkey when I was working in medical hospitals as a clinical psychologist. And then after that, through my graduate studies at Central Michigan University, I got interested in the assessment of neurodevelopmental disorders. And since then, throughout my training, I have continued this interest both in the research area, clinical area, consultation, and advocacy area. So today, what I'd like to achieve is really introduce you the basics of some of the more known neurodevelopmental disorders and talk about some of the red flags, symptoms, prevalence rates, and at the end, I'll talk about how we can assess, how we can screen for these disorders, and what should parents do if they feel that their children might have any of these symptoms of these disorders, and how should they go about having their children evaluated, and what are some of the common treatment methods that they can also have. So I put down here my email, and after the webinar today, if you have any questions, if there's anything that you'd like to follow up with, please feel free to send me an email, and I'll be happy to provide some answers to the best of my ability. And my goal is also to take some questions after each disorder, hoping that maybe there were some areas that you'd like to follow up with questions. So we'll welcome those questions in the chat. And Dr. Mehmet will read some of those questions after each section, and I'll do my best to address them. So overall, developmental disabilities. So when we think about developmental disabilities, what we should understand is that the development of a child is arrested at some level, and this happens in early childhood. So having said that, developmental disabilities do appear in the early years, usually the time that before even the child enters elementary school. And when we say developmental disabilities, what we understand is that a set of areas that are delayed in many areas. That could be in the area of cognitive functioning, which is IQ, our intellectual functioning. It could be in the area of taking care of ourselves, which is our daily living skills, like how they dress, how they eat, can they share their needs, can they take care of themselves, of course, age appropriate. It can be in the area of interpersonal relationships, which is, can a child make friends? Can they engage with others? Can they converse and talk in a meaningful way? Their communication skills, their basic language skills. Or we can see some delays in the motor area, such as fine motor skills, their ability to use their hands to write, to put some things together, to open jars. So those are called fine motor skills. Or in the area of gross motor skills, which means ability to ride a bike, throw a ball, hop. So those basic motor skills. Or it can be some delays in the area of social functioning, meaning that they may not enter a group, they may not initiate social interactions. They may be very withdrawn, or they could be overly aggressive towards their peers. They might not know how to relate to their peers. And finally, it could be in the area of academic functioning, which is when they are in preschool, they could have a hard time learning basic concepts such as colors, shapes, numbers, letters. So we could see some kind of delay within those basic skills, which could also carry over in early elementary years. And then we could see something such as reading problems, problems with writing, problems with doing math, which we will later talk about as specific learning disabilities. So when it's early on and when we see the onset of all of these delays or some of these delays, these would all constitute as developmental disabilities. So within these developmental disabilities, what kind of disorders do we see? The first one that we see is what we called ID, which is called intellectual disability. So I just want to make sure that maybe some of you have heard this, some of you have known this as mental retardation in the past, but the current terminology for this is intellectual disability. So intellectual disability, what this means is that this is a disorder where the child has intellectual delays and intellectual impairments, meaning that when we do an evaluation, we will find that their IQ is lower. So what does that mean? It means that their ability to solve problems, engage in reasoning, and then apply all they have learned in daily life is everything is below the average range, okay? Of course, that will have some implications mostly at school, that they will not be able to learn the concepts. They will be more delayed in those areas that will impact maybe their language development, their social development, and their ability to take care of themselves in the daily life. So based on how severe the intellectual disability is, we could have a category as being a mild. So that could be that they could have some problems. It could be moderate, needing more help and more supervision from parents or caregivers, or it could be more severe and profound where the child would need lots of support from school, lots of supervision, and a lot of different therapies and interventions to be able to learn basic daily living skills and then to engage in things like academic functioning. So as I mentioned, as like any of the developmental disabilities, intellectual disability is there before age 18. So if you know someone and that person is already 24 and somebody says, I think this person has lower IQ or is not able to maintain their day-to-day life, I think they're developing something. Well, ID cannot be developed after 18. ID is something that is there from really early on, okay? So the prevalence is around 2 to 3%. So it is prevalent. And most of the cases are, or clients usually have mild intellectual disability, meaning that their cognitive scores, if we think about the bell curve, if we think about IQ as somewhere between IQ of 90 and 110, and kind of like 2 standard deviations below would be an IQ of 70. So that would be an area where we start to be kind of like concerned about cognitive functioning and a lot of delays in adaptive functioning. So when we say adaptive functioning, that's our ability to take care of ourselves on a day-to-day basis. So when we have both of those, both lower IQ and lots of impairments and deficits in the child's ability to learn basic life skills, that means that there is a delay in both of those areas, and that would constitute as a child having an intellectual disability. So then some of you might say, why does this happen? So a lot of it is genetic, and remaining is we don't really know the etiology. We don't really know the reason why it happens. So there could be some prenatal events, like a mother, for example, could be on a medication for epilepsy. They could have malnutrition. They might not have access to medical care and prenatal care. They might have experienced a lot of adverse conditions where they were not able to take care of themselves. Sometimes there is exposure to certain medical events. There could be things like lead exposure, and probably, as again, all of you know, or some of you, most being from the Michigan area, you remember Flint, Michigan, and then all the lead exposure. So unfortunately, that exposed a lot of the kids to have intellectual disability as they kind of like grew, because lead accumulates in the brain and therefore would cause a lowering of cognitive functioning. So there are many, many other factors, but also there is a genetic factor there as well. The most common causes of intellectual disability would be Down syndrome, which I'm sure a lot of you are more familiar with, and then Fragile X syndrome, and then fetal alcohol syndrome, which today I will be talking about. But the other genetic or chromosomal abnormalities can be diagnosed much earlier than the other neurodevelopmental disorders that I will talk today. And for that, if any of you suspect that there could be some genetic cause by maybe looking at the child's face, that there could be some facial anomalies or things that we would not necessarily expect in a neurotypical child, then referral to the genetics department in any of the children's hospitals or in a hospital would be warranted and would be really helpful. And then they could kind of like do some engage in genetic testing. And therefore, some of these syndromes could be easily diagnosed. Especially Down syndrome is very easy because it can even be diagnosed prenatally before a child is born. So in terms of that, the etiology, as I said, it's kind of like mixed. So as I mentioned, one of the leading causes of intellectual disability is what we would call fetal alcohol spectrum disorder. Again, if we were live, I would, not live, but just face-to-face, and at that chance, I would ask, have you heard about this disorder? I mean, maybe a lot of you have heard about intellectual disability or mental retardation, or ADHD or autism, but not a lot of people are familiar with fetal alcohol spectrum disorders. But having said that, I'll tell you the prevalence. Prevalence is 2 to 5%. That's even higher at this point for than some of the ID or autism even presentation, that a lot of people know much more about autism. So then you might say, why don't we really know or haven't really heard about this developmental disability? Well, one reason is that fetal alcohol spectrum disorder in any diagnosis under this occurs only if a mother drinks alcohol or consumes alcohol during pregnancy. This is the only condition. If there is no alcohol consumption during pregnancy, there is no fetal alcohol spectrum disorder. Therefore, it is the number one preventable cause of intellectual disability. So in that sense, as mentioned at the very beginning, I do a lot of trainings, a lot of programs to engage in that prevention and sending in the message. So one very clear message that I think we all can share, whether we're professionals or just individuals interacting with people around us in many different ways in our own professions, is not a single drop during pregnancy, because we at this point, we do not know how much is safe to drink, because we cannot engage in those studies specifically and have those experimental groups where one group will drink one, we cannot engage in that kind of research. What we know from the animal research, and then later on, when we look at the brains of individuals who have been impacted, what we know is that alcohol is a teratogen, meaning that it passes through the placenta, and the unborn baby's brain is so young and is so small at that point and underdeveloped that it cannot consume alcohol like an adult brain. When we all drink alcohol, it passes through, it goes through the body, and it just gets out. But that's not the case for an unborn baby. It stays there. And what does it do when it stays there? It starts to damage the different brain functions. And at the end, it causes brain damage before a baby is born. So then what are some of the issues that we see? So if you are interacting with if you're maybe in the position of working with children, if you're teachers, maybe a lot of teachers do see these. What are some of the symptoms? Well, one symptom is cognitive impairment. So intellectual disability and FASD can go hand in hand, and they can co-occur. So in some of the cases, then we would definitely see lower IQ. We would see a lot of behavioral and emotional dysregulation. What does that mean? It means that children have really hard time settling down, and they can become very aggressive. They can engage in risky behaviors. They could be very irritable. very impulsive, very disinhibited, meaning that they cannot stop their behavior. So similar to, you would say, maybe ADHD. Yes. Up to 70 or 80% of the individuals who have FASD also have ADHD. And you could say, why is that? Because alcohol interrupts and disrupts and damages the same brain structures as ADHD. Whereas ADHD, the cause is genetic. For FASD, it's all due to alcohol. Okay, so therefore we would see a lot of the similar ADHD symptoms. We also see a lot of deficits in their ability to comprehend. So we would see a lot of children with FASD engaging in very risky behaviors. They could put themselves into danger. Up to 70% of them get separated from their parents because of the circumstances that they're born, because the family and the mother or the family continue to engage in substance use. And therefore they get separated, and they're usually in the system, welfare system. And then 70% of them do also engage or get into trouble with law because of that lack of judgment, which is also the part of the brain, the frontal lobe, where individuals engage in decision-making, judgment, problem solving. So a lot of those skills, which we call executive functioning skills, do get impacted, okay? So as a result of that, we see a lot of problems with understanding cause and effect. So an example would be a child goes and crosses the street, and then the truck was coming, and then the mother is just in tears and just is screaming the child not to go and trying to go after the child. And this is like a 9-year-old. Well, 4-year-old could do that, but by 9, we should really know that you have to cross and you have to look before you cross. And then when asked later on, what were you thinking? And then the child says, didn't you see the truck that was coming? The child says, yep, I saw it. So then why did you cross? Well, I didn't think that the truck would be coming at the same time as I crossed. So there is that disconnect. And that's what happens with FASD. A lot of the children with FASD are very bright, and they do not have any problems with that, cognitively, but they have a lot of difficulties with connecting this information. So we see a lot of that disconnect where it leads them to need a lot of supervision, a lot of help, a lot of structure, and a lot of accommodations in their home and school environment. We also see a lot of problems with adaptive functioning, which is their ability to dress, feed themselves, make friends, a lot of problems in those specific areas as well. Of course, along with that, the comprehension issues, we also see a lot of problems at the school too, with learning, and specifically math learning disabilities are pretty common in fetal alcohol spectrum disorders. As I put down here as the secondary disabilities. So if FASD is not caught and treated early on, which you might say, what can we do after there has been some brain damage by alcohol? There's a lot that can be done. Again, in my other webinars, I talk more specifically into some of those treatments. However, a lot of behavioral therapies, a lot of therapies on teaching behavioral regulation to children with FASD, a lot of educational interventions, they can lead very successful, steady lives where they keep learning, because our brain is plastic, meaning that our brain is evolving all the time. It doesn't stop producing new networks and connections. That's the beauty of the brain. But if we do not catch that, which we know that for FASD, the mean age of diagnosis, so when did they get diagnosis? 9.5. That's way too long. We have passed that wonderful 0 to 3, 0 to 5 age range where they can get a lot of interventions in place, right? So, but if we can't catch them on time, then they get misdiagnosed with ADHD, with bipolar, with all the other type of mood disorders. And then they get into trouble with law. They could develop some other mental health issues. They can get into drug and alcohol use due to their impulsivity. So then all sorts of problems and secondary disabilities do arise. So I think I kind of talked about this piece that only for children whose mothers drank throughout the whole pregnancy, okay, and they had a chronic use, like it was like not one-time drink, right? But it was a chronic use, then they would develop what we call fetal alcohol syndrome, which is the more severe form of FASD. So what does that mean? It means that they actually have some facial features. So these are children, as you can see, from different races and ethnicities, where first of all, they would have a growth deficiency, meaning that their head circumference is below 10th percentile. They have a smaller head, which we call microcephaly. They would have weight and height below the 10th percentile. So again, and if you know any other children who have hard time with gaining weight, failure to thrive, that could be also FASD. And then they also have facial features. So as you can see on the slides, all of the children, their eyes, what we call epicanthal folds. So they have a specific eye shape. Their nasal bridge is not there, it's very smooth. And then they have short nose, and then they do not have a philtrum. Philtrum is the area right here. If you all do this, we have a little bit of a bump going up here. So they do not have that. As you can see, it's very smooth across all races and ethnicities. And the reason is that alcohol disrupts the midline of the brain, and midline is the midface. So that part kind of gets smoothed out as they are born. And on top of that, they also have some problems with different organ systems, that they have eye problems, heart-related issues. Again, all of them in the midline of the body as well. And also they have the neurocognitive, regulation, adaptive deficits that I've already talked about. So just as just to show you and the impact, the one on my right, the one that's smaller brain, is a brain of a baby who died and had FASD. So as you can see, and then the one on the left is another baby who died of sudden infant death syndrome. And that's a more neurotypical kind of brain that was fully formed, that has all the different connections in it. It's large, as it's supposed to be. And the one on the right has shrunk considerably. So that's what alcohol does to a brain. It shrinks the brain. And when we say it shrinks the brain, it means that it's smaller in size. When we have a smaller head size or a brain size, it means it cannot carry on the functions as it should, because there's not even enough space in the brain and enough connections. And some of the neurons, which is the brain cells, have already died before the baby was born. So as you can see, it's a very dire consequence. So the message, I think, for all of us to give to anyone that we could see of childbearing age is not a single drop of alcohol during pregnancy, or if there is someone who is contemplating on getting pregnant, because they might not even know they're pregnant for the first 4 weeks, 6 weeks, right? So refraining from that would be the best way to go. And if you're all in a position to maybe work with young, women, I think that's probably definitely helpful information, because sometimes we still hear from some of the medical professionals like, oh, one glass of wine, just will help you to relax and so forth. There is really no safe amount of alcohol, because what if that wine was drunk on the night a baby was developing that part of the brain? We cannot know, because all of us develop in a different way. So I think I talked about some of these areas, specifically what their profile, some of those symptoms look like, but most is impulsivity, decision-making, planning, organization. So a lot of that frontal lobe or organizational judgment-related issues, comprehension issues, and very specific memory issues. So for a 3-4-year-old, you teach them concepts. This is red, this is blue. They learn it. Well, after repetition, we've all seen or sent our children to preschool probably, or to daycare, and they came back and, Mom, today I learned this. And then the next day you hear them say it again and they do it, right? So kids with FASD, they have a really hard time retaining what they have learned. So again, any of you have any children around that you're observing that they're having hard time learning the basic concepts like numbers or letters, or even before that, things like colors and shapes. It's just you teach them, 10 days later, it's not there. That's a memory related issue. Well, we don't expect memory issues in a 3-4-year-old, right? We would expect in someone maybe with dementia later on, or if they had a traumatic brain injury, but not with a young child. We expect them to move forward and to keep learning. So if that's happening really early on, we should be really suspecting of some of these developmental issues, especially fetal alcohol spectrum disorders. So before I move on to autism spectrum disorders, I wanted to see if we have any questions. I can see there's one chat, but I can't see the chat. So I'll just take some of those questions now.
I don't see any questions on the chat. Is there anyone who would like to ask a question about ID?
ID and FASD?
FASD, of course. I have one question. I might have asked this question on your previous webinar that I attended, but is it possible that kids might develop this FASD because the mom has drank before the pregnancy? Before pregnancy behavior has any impact on kids' developmental growth?
That's an excellent question. I think remember maybe different formats with the fathers. I'll also add that in there too. So if a mom drinks before conception, there is no impact. So it's all about when, after, conception, then of course, a lot of people don't know that they're pregnant, right? A lot of women don't figure out. So that's why I said that if a woman is contemplating or wanting to get pregnant, that's also a great way to refrain from alcohol. But if they drank before, it does not cause FASD. Okay, it's all about right after conception, but right at conception it starts, because at conception the baby starts developing right away. Okay, so even that the first 18 days is extremely important after conception, 18 to 24 days, because that's when the neural tube, which makes up the brain and the spinal cord, it closes. So a lot of the birth defects do happen also at that very, very early time that a lot of women are not even aware. So having said that, I get a lot of questions about what if the father, it's all about on the mom. What if father has drank, during or, before, conception? Is that going to have an impact? Again, it's not going to cause FASD. However, what it's going to cause is that alcohol passes to the sperm, so it's going to decrease the motility and the quality of the sperm. So that could lead to, so if a man has substance use issues in the form of drugs and alcohol, it will decrease fertility. So that will impact the quality and the ability to have children. So it will definitely impact that part. And then if a person already has substance use problems, that has a genetic component a little bit. So that will genetically pass to the child. It will not cause FASD. However, it will lead the child to be prone to develop substance use disorders, which could be using drugs or alcohol in the future. And of course, the home environment and modeling will also, of course, have an impact on whether the child or a teen later on will develop a substance use disorder. So those are the two things. But really, if any of these do happen still, and the couple gets pregnant, and if there is no alcohol consumption, we will have no FASD. That's the good part. But the ID, if it's genetically there, we cannot prevent that. It's just meant to, it's meant to be happen because a lot of it is genetic, as I mentioned. But FASD, there's nothing genetic there.
Perfect, thank you. We have one question on the chat. Ilya Erol Garvat is asking, you mentioned if someone is diagnosed with this at the age of 20, does that mean that person is born with this condition?
I'm assuming if they were diagnosed with FASD, right? Mm-hmm. Just to clarify so I can give a correct response. So if an adult, and that's a great question, so thank you for that. I also get a lot of referrals for adults, not just only children, because we are now getting to know more and more about FASD, and then someone who is now 20s, 30s, when they were younger, people didn't know all about it, and they probably have been missed in terms of the diagnosis. Therefore, we do get a lot of adult clients who are seeking for a diagnosis. And if they have been diagnosed, that means that they were born with that. because FASD is something that you're born with. It is just hard to diagnose because unlike substance exposure, which when a baby is born with substances in their system, they can be tested on their heel when they're born, and we can determine, doctors, not we, not I, doctors can determine if they have been exposed to substances in utero prenatally, okay? But there is nothing like that for alcohol at this point. So unfortunately, that's where we are. So therefore, we sometimes miss it, and it's not an easy area to develop all of this testing. So therefore, it means that yes, they had it all along, but the degree could have made a difference. We have some adults and individuals who had the milder forms. They don't have the facial features. They have a high IQ. They just have problems with decision making, planning, organization, adaptive skills, and so forth. But they grew fine. They didn't have the facial features. So that means they had the milder form. Maybe that's why also they weren't diagnosed. They went under the radar and fall through the cracks. But they definitely probably struggled a lot till that age. So yeah, that's true. You see some.
Doctor, I have a question too. So you said what percent of the babies get FASD? I think you said it, but I missed it, so I just want to confirm that.
Thank you. The current prevalence rate is 2 to 5% in US and 2 to 5 as well. So we looked at both of the prevalence studies abroad and then in US. US and abroad, they now match to, it's 2 to 5%. Okay. And the latest study was done actually in Midwest, in the 4 Midwestern country, counties and so forth. So it definitely is very high. It is higher in abroad in South Africa. There is a ton of studies from South Africa, in Russia, and we've got some more prevalence in Italy. And as you can see, also there is some convergence with consumption of alcohol in the countries. And then we do also see a lot more in Canada and in the reservations, and that has that link between higher rates of alcohol use related issues, for Native Americans. And again, we probably, and a lot of you know about that as far as like in the conditions that they've been forced to live with, and a lot of the mental health issues that's driving the substance use related issues. So when they also consume, then the likelihood of having babies with the FASD, of course, goes higher. Nothing to do specific with the race, but it has to do with the contextual and the environment that they need to live in.
May I ask one policy-related question?
Yeah.
I know the governments are always trying to protect the vulnerable populations. They limit the alcohol consumption and smoking among children. Is there a regulation for pregnant women to consume alcohol? Is there any laws against it in other countries around the world? I know US doesn't have. We have suggestions that the pregnant woman should not drink at all. But is there any other countries that has restricted this alcohol consumption among pregnant women?
I haven't really seen or heard about that, because as you all know, drug use is, that's a felony, right? And especially when, mothers are using it, then what happens is that there is that differential handling of it from the policy perspective. So if a mother consumed drugs during pregnancy, even in US and in some other places, when the baby is born, the social welfare system steps in. They might lose their child to custody or not. Some they work together until the mother is stable, and then they can reunite. But a lot of the times they can, the babies can get taken away. We do not have that same thing for alcohol, because alcohol in general is legal. I think that's the issue. But I will not be able to tell you that for maybe some of the Middle Eastern countries where alcohol is overall prohibited. So I'm not really sure and positive about those countries where alcohol is prohibited. But in countries where alcohol is not prohibited, there is really no specific law for pregnant women consuming, alcohol, of course, including US there as well. So let's say That's another reason why with the lower maybe prevalence rate than we might know, because if women drink during pregnancy, they prefer not to share it with their providers because they'll think that, you know, my baby can be taken away, and then they suffer in silence. But if they share, actually, there are really good programs to, you know, help them out during pregnancy so that they can actually stop, but in a meaningful way. It's the same for drug exposure, drug use during pregnancy. There are a lot of methadone, like a lot of programs where they actually give these drugs to women in a controlled dose and then titer it down so that they can actually, you know, not use or overdose, which will very much impact the unborn baby. So the better thing is for the mothers if they do engage in, because they don't just, no mom will drink alcohol just for harming their baby. No mom will do that, because they do it because they have a substance use disorder and they cannot control it at that time. So they need assistance, they need help, but a lot of them cannot because one, we know that there is racial and mental health like disparities among groups, and therefore some of them do not have access. Some of them are scared. Some of them are prevented by their significant others to go and get help. So there are a lot of, you know, unfortunate reasons why women cannot have help or access for help, so that they can be, you know, connected with good resources where we can actually prevent it. So whenever they can stop, it's just like smoking, right? What did the doctors say? Whenever you stop, please stop, because it's good, right? We can just save some part of your lungs. It's the same thing. When a woman can stop at any time during pregnancy, that's great news, because the more exposure means more damage in the brain. Same for substances.
Thank you.
Yes, those are the questions for now. And then if there is any other as we move along, I'm happy to still sit there and to answer more questions. All right, so let's see, I'd like to move on to autism spectrum disorders. And I would think that maybe more of you have heard of autism than probably FASD. So autism is, again, a neurodevelopmental disorder. Again, remember, we're saying neurodevelopmental, everything before age 18. No one will develop a neurodevelopmental disorder after they're adults, okay? It means that if we didn't know about it, and if they get diagnosed, they already had it all along. So that goes back to one of our audience's question for sure. So autism is a developmental disability that we see more in the first 3 years of life. So as opposed to FASD, it's a little bit more easier to diagnose because we see some of the signs really early on, okay? So I'll talk a little bit about those, but this is a disorder where we will see a lot of problems with social interaction with others or difficulties with. We will see a lot of difficulties with engaging with other people, engaging in repetitive behaviors, okay, self-stimulatory behaviors, stereotypical behaviors, and I'll give some examples later. And some children do not develop language. Some children are nonverbal, but some children do develop language. They have really high IQ, but then that's why it's a spectrum, right? It can go from mild forms, level 1 to level 3, which is more of the more severe forms. So currently we do not have any medical tests. I get those questions a lot. Is there an MRI? Same for FASD. Can we just figure that out at age 12 months? The earlier the better, right? Yes, earlier the better. At this point, we do not have those imaging. There are a lot of studies that look at that, and I think quite soon they will come up with things, but not at this moment. So our best bet for autism is at age 18 months. That's the earliest that we can diagnose, which is good news because then we can start the early intervention process and then to start those therapies. The better news for ASD compared to FASD is that the mean age of diagnosis is 4 to 5. So I think we do a much better job of getting there, screening for it, and coming out with the diagnosis. Maybe some of you will remember who have young children now. At around 18 to 24 months at your pediatrician, you probably filled out a questionnaire called CHAT, or some others maybe that you might not remember now, but it asked about some of those autism symptoms. So we do a much better job of screening for autism at all pediatricians, meaning that a lot of people go take their children for well visits, right? So that's when we can kind of like screen for autism and then figure that out. And if the pediatrician is like, that's a positive screen, I need to refer you to a psychologist, to a developmental specialist, to get the full evaluation to see if we see any of these issues. So it's more prevalent in boys than girls. So that's another important information. So what are some of the symptoms? Some of the symptoms is one big one is around social interaction. So kids with autism have really hard time engaging in that reciprocity. Reciprocity is, when we're babies, what do babies do when they're, feeding? They look at the face of the mother or the father who is feeding them, right? And so when you see them smile, you smile them back, right? So kids with FASD, they have really hard time with that reciprocity due to the mirror neurons not working as effectively, meaning that they have a hard time learning from imitation, learning from modeling, okay? So therefore, kids with ASD have hard time gesturing. They do not use their gestures. Well, as you can see, and also being a Turkish person, we all, I think culturally do, we use our hands a lot. I'm trying not to because Zoom is not the best for that. I learned it through my teaching. I'm telling you, Dr. Ergun, just stop moving your hands that much. So it's that not being able to engage in those gestures, not being able to understand facial expressions. So like if I'm smiling, then another person would engage in talking, they smile back, okay? So if I'm kind of serious, we regulate each other. We kind of learn from each other's facial expressions. We study individuals. So, but that is very difficult. So what does that lead to? Well, if we cannot understand, so like, let's say I'm seeing some of you, you seem all engaged and kind of interested, hopefully. So I can just say, if you're smiling and not, then, it makes me motivated. So that's how we understand the cues from others. And that's how we continue our interaction. So kids with ASD, because they have hard time getting these cues from others, they have hard time with that social interaction, okay? So what do? Don't they interact? Of course they do. And they have beautiful interaction. I love my kids, or my autistic kids who I've interacted with and I've evaluated. They have this dry sense of humor. They have a hard time sometimes understanding humor, but they have their own way of interaction. They love to talk about what they're interested in, very much, to the point that they are really experts on it. They're little professors, sometimes they're called that. They want to learn so much about a certain topic, and they ask questions, they read about it, and so forth. But the only difficult way is that they tell others, it's like a monologue. When it's time for them to ask others questions, like, and then what do you like? They don't ask that part. So the interaction stops there because they want to share everything, but they don't engage in that reciprocity. So that's one of the difficulties. Another difficulty is the nonverbal communication. They don't do a whole lot of, especially when they're young, they have hard time making eye contact. They can look elsewhere and still respond to you, but they would not make that eye contact when you call their name. Those are the first symptoms that we would be concerned about, not responding to their name, and they don't have a hearing issue. Hopefully that's been checked. They don't use gestures. They don't use their hands. They don't point. They don't clap. They don't do the social games like pat a cake and itsy bitsy spider and those type of things, okay? They don't use their body language to interact, with others. And all of these, of course, lead to social interaction difficulties. They have hard time initiating friendships, meaning that initiating social interaction. So that would be the kid who would go to the park, they would play by themselves. Whereas another 2-year-old would be just like screaming and trying to latch onto someone and run together with another child. Whereas our autistic child would wanna be with them in the same spot, but play on their own, not wanting to interact, and they would be totally okay with that. They also don't do a lot of imaginative play, which is our pretend play, right? So I could say, whoo, this is a plane. Well, this is a pen, not a plane, but I could do that and have fun. That's called pretend play. They don't do that. They just only play with things as they are intended. So therefore, we would see lack of friendships and peers and lots of issues with joining in groups and things like that as they grow. Another issue, which is the last part, is restricted interests, meaning that they get interested in a topic so much and they cannot get out of that piece. You try to talk them into other things and then they steer it back. So to give an example, I had one 6-year-old at one point that I evaluated. He was obsessed with starbursts and he would color code them when he got them. And he always liked the red one. He chose that. And he wanted to talk about how good it tasted, how he coded them, how he separated them and so forth. And I would ask him about, what about your friends? He would start talking to me. Who's your favorite friend? And I would say like, well, I have Michael, and then I have John, and then one day we were eating Starbursts, and and one of them got my red one. I got really, really upset. So we're talking about friends. It's going back to their, area of interest. So that's also another, area that they have hard time transitioning. They have difficulties with that, what we call cognitive flexibility, which is when they grow up, we see a lot of that black and white thinking, not being able to move from one thing to another. If you tell an autistic child, okay, without any cues or reminders, okay, now we're done, we're moving to this next, we're gonna go and do another activity, they can have a temper tantrum, they'll have a meltdown. So they need a lot of reminders that we are transitioning. So the part of the brain that kind of tells and give us the signal. Right now, if I say, I can't do this anymore, I have bad connection, we're done. We go like, oh, okay, we're sorry, but okay, right? So we're transitioning like that. Nothing like this happening. But for a kid with autism, that's an extremely difficult thing. You cannot just do this like that very easily. So those are some of the things that we would notice, definitely. Also, a lot of them do have a lot of eating difficulties, meaning that they have very restricted eating patterns. They can only eat certain type of foods, a lot of GI type of issues, sleep problems, language delays we would see, and then sometimes we would see regression between the ages of 18 to 24 months, which means that was a typical developing child. Everything was going well. They weren't even talking. They stopped talking. And then the parents get very, very worried, of course. They take them to the doctor and then they do evaluations, and we could see that that's when autism could emerge, okay? So looking at that regression piece is, of course, important. And then the last piece is sensitivities, which is they can be very hyper or hyposensitive, meaning that they can be very sensitive to light. They want it all dark pitch. Black when they sleep, for example, they don't like sometimes that touch too much. It could be too much. Even if you do this, they could say, you hit me. It just hurt a lot. They have a hard time getting their hair cut, nails cut, because they feel it so much. It's again related to that part of the brain. Loud sounds really bother them. Again, not all of them because this is a spectrum, but loud sounds and bright lights. Where is that? Malls, festivals, where there is like these, Disney, all of these big places where there's a lot of stimulation. So they do not do well with a lot of stimulation. They get overwhelmed really, really easily. And at the end, what do we see? Meltdowns, aggressive behaviors, wanting to escape. You would think that, why are they running away? Because they're overwhelmed in a sensory way, okay? So as a result of that, of course, they have difficulties in many, many domains. That's why it is a big spectrum and a disorder where our job then becomes to figure out what kind of areas that they struggle in. So let's see. So I do a little, well, oh my goodness, I have 5 minutes. I talk way too much. Then we have these two areas. I think I'll go on then and take questions maybe for those who can stay, because I don't want to take anyone else's night. I know it's late today, but specific learning disabilities are when a child has normal IQ, okay? They can cognitively do anything, but their achievement is not up to par. That means there is a discrepancy. Although they are very smart and capable, they cannot learn. That's what we call a specific learning disability. It can be in reading, writing, or math, okay? And for this, we need to do specific testing. A psychologist needs to do a testing. with cognitive skills, IQ, and their academic skills, and figure that out. And we have wonderful interventions, especially within the school system, where they can get what we call individualized education plan, IEPs, or accommodations, which are special education interventions at school, where they work with those children with learning problems one-on-one, which is wonderful. So these are some of the areas. And then our last topic is ADHD, which I'm sure a lot of you are more familiar with. More males than females. And it's close to, 9%. So it's much more prevalent than all the other ones that we have talked about before. Okay. So it is a very common referral problem. A lot of my evaluations are, is this ADHD or not? Is this or ADHD between all of that? ADHD is also genetic. So if there is someone in your family with ADHD already diagnosed, there's a high chance that could come around and appear. But some of this could be environmental, which could be that gene and environmental effect together put in there. So some of the things can lead to and exacerbate that, like lead exposure, insecticides, a lot of the chemicals, artificial food dyes. Those do not cause ADHD. I just want to point that out. They could interact with the ADHD gene and help it to express out. Okay, so it's not like they do specifically cause that. It doesn't. Bad parenting doesn't cause any of these neurodevelopmental disabilities, by the way, because I see a lot of this. Sometimes parents say, did I do something wrong? Did I eat something wrong in pregnancy? Unless you were exposed working in a factory and exposed to chemicals and things that could alter the genes, really none of that stuff. Of course, good nutrition always helps with a healthy baby, producing a healthy baby. But sometimes I get questions like, I work outside of the home. Is that why my child needs attention at home? No, they were meant to have it, and that's more genetic. So more boys again than girls overall. And it's also very common in the other rest of the world there as well. In adults, it's a neurodevelopmental disorders mean that it doesn't stop after they're 18. It means it's a lifelong condition. Okay, so it just changes form. All of these things get ultimately much better and much easier to deal with and manage as children grow into and become adults. So that's the good news. But hopefully they have the diagnosis, and hopefully they have received appropriate interventions. So I put down some of the inattentive symptoms. So giving close attention to detail, making these fast, careless mistakes. 2 times 2, they know it's 4, they put 5. Okay, they think it's a multiplication instead of plus sign. You can just see some of those errors. Hard time keeping the attention, daydreaming, just kind of like a lot of that. You give them an instruction, you tell them, oh, can you go upstairs, pick up your bag, and then come back, and then tell your sister to come down. They tell the sister to come down, the backpack is upstairs. They do one part of it because their attention span is short. So we need to give shorter, definitely, instructions. Hard time with organization, the backpack situation, for those who have kids, organizing homework. And then when they're adults, with managing work, deadlines, knowing when to do what, paying bills, all of those could become really hard when they're also older. Losing things, that's a big thing. One glove comes, the other, is at school. Very forgetful, very easily distracted. They see a sound, they're the first ones to look what's going around rather than concentrating on their issues. So we have the inattentive type. So we could diagnose a child, and that child could have no hyperactivity. So we would call that inattentive presentation only, which could be managed by medication. And then we have the hyperactive one, which is the ones our kids who are bumping from place to place, fidgeting all the time, leaving their seats, running around, chatterbox, we call sometimes talking excessively, blurting out before the question is answered, have really hard time waiting their turn and interrupting others very frequently. And sometimes we have both, which we call combined. They have both inattention and, and then they have the hyperactivity all at the same time. So what do they struggle with? Well, they struggle a lot in school in terms of whole executive functioning issues, which is their planning and organization. Deadlines, group activities are really hard because they do their homework, they forget to submit it. A lot of those issues. And then they have a lot of also difficulty with what we call reaction time, which is they don't react on time. They're impulsive, but they don't react when they're supposed to. So those are different things. And then you could say, well, a lot of the kids do stay on video games for 5 hours. Why can't they attend to a 20-minute lecture? Well, I'm sure you know the answer, but the video games are interactive. So kids with ADHD are drawn to what we call novelty. Anything that's moving, novel, and anything that gives them immediate reinforcement, which is all the video games, right? They give you, like, you push it, you get all the points. Great, that's immediate. Well, is life like that? No. For those of us who've done the PhD, we had to wait 5 years, really? Yes, and we did. So kudos to us for waiting that. But you know, in real life, they just need that immediate reinforcement. So if you're working with a child with ADHD, giving those short reinforcements, you do this, then you can get that. And then the brain rewires itself and helps to rewire that process of learning to wait a little bit longer, and not acting impulsively, okay? So how do we assess and intervene? So the just last 2 slides, I know we're almost there for time, but so if you have any of your children or your family, any of those who you're working with, you have any of these red flags or symptoms that you've seen that you thought like, well, maybe. First is starting with a pediatrician. You can go to your own regular pediatrician, family doctor, but more pediatrician because they're more trained to work with childhood disorders, and or developmental pediatrician. That's more preferred because they have more specific information on developmental disabilities, and they would screen for any of these developmental disorders once you tell them your symptoms and why you're there. Then they can refer to someone like me, a clinical psychologist. Neuropsychologist is another profession where they do just testing and evaluation assessment for many of the brain-based disorders. And then if they have problems with fine motor skills, if they are behind, they can refer to an occupational therapist for the sensitivities and all other issues. They have a hard time with their motor skills, physical therapists could help. If they're delayed in their language, we can refer to speech language therapist. We can refer to genetics for some of the FASD or some of the ID, like Down syndrome, Fragile X that I've talked about. And then if it's caught really early, 0 to 5, we have great programs in different states where early intervention services are free, okay? And they can get to receive these early intervention specialists, and they can start working on some of these delays. So a lot of these people work together, and then the main approach is interdisciplinary approach. So a lot of the places that I worked so far in the children's hospital specifically will have what we call a developmental disabilities clinic. That will be the best place. It's one shop. You take them, and then all of the people that I talked about, they do their own evaluations. You don't have to go to 5 different places. They can get them evaluated. They'll write one report. They'll sit down with you, and they'll come up with a treatment plan. So your children's hospitals, developmental disability clinics are the best bets once it's determined what's going on. And finally, what are our treatments for most of them? Again, I have tons of information on each of those specific treatments, evidence-based treatments, but as generally, we have, once a child is determined to have a developmental disability, once there is a diagnosis and a report, you need a report, okay? Then you can go to the school and ask for what we call IEP. IEP is an individualized education plan where all children who go to school, okay, until they graduate, K, and even after till age 21, they are eligible for free for any special education services. That's US. We don't have that in Turkey. So, they're blessed to have that system here. So that's what we call the special education services, or they can have accommodations, like we'll have them sit in front because they have ADHD, they get distracted. We want them to sit in the front, but it's not temperamental. It has to be implemented so that the child is successful. We have a lot of behavioral therapies that are really, really helpful, where we engage in parent training, where we teach parents how to manage disruptive behaviors, okay? Or any type of behaviors where we teach the children how to regulate themselves back, okay? Also, a lot of these disorders have what we call comorbidity. Comorbidity meaning that if you have ADHD, you might also have a learning disability. If you have autism, when you're a teen, you might develop depression. So we need to make sure that we just not only treat the primary disorder, but we treat what also comes along with it, because a lot of those do lead to things like suicide, attempts and substance use issues. We have to treat those as well. And some of these disorders would benefit, especially ADHD, would benefit from medication management. So working with a child psychiatrist for medication options is going to be helpful. And a lot of the developmental disabilities would also require support from a social worker in what we call case management. Case managers or social workers are wonderful people who would be able to help the family, because remember, all the providers that need to take, work with the child, that's so much to handle for the whole families, right? How many places can you take a child one day and still take them to soccer and extracurricular activities and still have fun time with your child? So you need someone to organize this, right? That's what the case management comes in. And then the last part is advocacy in the schools. And unfortunately, sometimes because of the judgment issues, problem solving issues, low cognitive issues, some of our kids with developmental disabilities do get into trouble with law. So that's why a lot of advocacy, legal aid is also needed, to help our children if they, happen to have that kind of a contact with the legal system there as well. Well, in a nutshell, this is a huge area, but then I put some of my references, but this is kind of like a little summary of some of the basic neurodevelopmental disorders that we can see. Hopefully that's helpful for some of the red flags to see what the assessment and referral process could be like. And then some of the possible, treatments. Of course, if you are in this area or if you go into this area, you'll be flooded with tons of information and it can be very overwhelming. So we also have a lot of parent groups that support each other once there is a certain diagnosis that can help each other and that can help support each other in these instances too. So let me see then what questions we might have as I finish this whole part.
Thank you very much, Gokce Hocam. There is a question that came. Oh, this is just a thank you, couple of thank you notes. I have one quick question. From all these developmental disabilities I have seen, boys or males are more likely to suffer from these disabilities. Is there a found reason why boys are more likely to have these disabilities compared to girls?
Yes, there is. So that's the, so when girls to become a female, then we got 2X chromosomes, right? And then for a male, it's X and Y. Okay. So when it's these are passed on. So with if it's a intact one, if it's an XX, then there is less likelihood of passing that. But when there is an XY, and if it's coming from the mother, then it kind of completely passes. And because then the males have the XY. So therefore, in all of the disorders, there is a higher incidence of having these more genetically. And as you can see, other than the FASD, pretty much all of them do have a genetic basis. And therefore, males just inadvertently are more going to be more susceptible to that just with their genetic and chromosomal makeup, unfortunately.
Thank you. Is there any other question in the audience?
Doctor, I have a question. I just want to look at my notes real quick. So is there a correlation with high IQ and ADHD? I have heard there might be one, so I just wanted to confirm with you.
Definitely. So in terms of cognitive presentation or cognitive profile, in children with ADHD, do usually have average IQ, meaning that average or high average. Okay. However, there is not really like a prodigy kind of a thing as far as like the higher the IQ, there is more likelihood of getting ADHD. So there's really no specific correlation on that. ADHD is genetic. So if there is someone in the family who has ADHD, then there is likelihood of the children having ADHD there as well. With IQ, we have more of that relevance for autism and then for FASD, because for both of them, we could have very low IQ, average IQ, and high IQ. And it's on a spectrum for both autism and fetal alcohol spectrum disorders. Whereas ADHD, unless a child has intellectual disability and then they have ADHD, okay, then IQ will be low. But then for our more typical children who have nothing else but ADHD, it's usually within the average range. And then, there are a lot of children who are also above average or in the superior range. But there is no specific correlation that says that if you have really high IQ, that there is more likelihood of developing ADHD. That's not the case.
Thank you for that. And also, do adults who have ADHD or adults who do not, their ADHD does not go away, by time, does age kind of make ADHD decline a little bit? Is there a correlation or a study from that spectrum?
Yes, you got that one. So definitely. So what we call this is the course of the disorder. When we say course, it means the presentation of the disorder for all of them, but the question's on ADHD, so I'll respond to that. So ADHD will be much more severe in terms of the symptoms and so forth when they hit the school age. Okay, so at 3-4, all kids are very active, right? We can all say they're all hyperactive. That's why we do not diagnose them when they're 3 or 4 or preschool age. Okay, we do not really diagnose before age 6 because it's just developmentally normal, typical. Yes, they will go around. So the worst symptoms in terms of hyperactivity is the school age, okay? And then when they hit puberty and then it's the teenage years, the hyperactivity dies down, okay? So what are we left with? Still inattention issues and impulsivity. Impulsivity doesn't really just go away. Impulsivity is just making impulsive decisions and saying something like blurting out, but not the jumping up and down. That kind of dies down, okay? And then from there, moving on into adulthood, the hyperactivity, really, really dies down. Okay, so what is it's replaced with? Because as we said, it's a lifelong disorder, right? What it's replaced with is restlessness, and we call it like difficulty with inertia, meaning that when you just sit like this, like in this webinar, just kind of like getting antsy and needing to, do something, to drink of water. So not just being able to concentrate. So that restlessness piece really takes in place of the hyperactivity. Inattention might not be as severe as the school age years, but then what we see is more problems with what we call executive functioning skills, which is difficulty with planning, organization, meeting deadlines, and then initiating activities. There is a lot of like, yeah, I will do that later. So just procrastination, difficulties with time management, okay? So they know when the deadline is and they say, oh, I'll get to it. So they have hard time traveling in time and saying like, whoa, if I don't do this in 2 days, I will not be able to submit this. So that's traveling in time, and that's a specific skill in our brain to be able to do that. So adults with ADHD have a little bit more difficulty with that one at that age, and a lot of like planning and organization, which could have some, impact on occupational functioning, right? And a job. Think about someone at a job and meeting deadlines, working in a group, forgetting their own parts, what they were supposed to do, needing reminders, right? And then difficulties with following like long lectures. So I work with a lot of, young adults in college. They have to have things recorded because sitting there, especially these days in front of the Zoom and so forth and listening to a 2-hour lecture is just really, really tasking. So those are some of the things that we see rather than the jumping up and down, the hyperactivity and so forth. And sometimes we see some impact on interpersonal and romantic relationships, which could be in the sense of not being able to listen what others say in detail, and more talking about themselves and just kind of more like a monologue. And when it comes to that interaction and sharing, not that they don't care or anything like that, they could forget that the other person had something to say and they could move on to another topic, which could make that, and then the other person might say like, whoa, I was gonna share all this, but like, okay, anyways. And then, things could start to get a little bit more, difficult between, partners and so forth. So those are some of the things that we see a little bit more. And the last one is problems with money management. So like some more life management, forgetting to pay bills, forgetting to like, impulsive spending. Also more engagement sometimes we see high rates of motorcycle and car accidents due to inattention issues. And then we do also see some difficulties with, of course, the impulsivity around substance use. So that's also something we always screen for when I have a young adult. I screen for a lot for the substance use part because of that impulsivity playing in there.
Thank you so much.
You're welcome. Any other questions?
Do we have any more questions? If not, it's 9:15. We don't want to keep Gokce Hocam any more than we promised. Thank you very much for this amazing presentation. I learned a lot. Hopefully people enjoyed the presentation as well. Hopefully we'll meet for another meeting for another topic. Thank you very much again.
Definitely. And thank you again for this opportunity. It's nice to meet, some of you also here in person as well, with the pictures and everything. Thank you for all your questions, and hopefully it will be beneficial at some point as you encounter individuals and some loved ones and so forth. And I'm happy to come back for some other topic